Well, good morning, everyone, and welcome to the last day of our annual meeting. I hope you have enjoyed the meeting thus far, and I hope you enjoyed last evening's gathering. It was a lot of fun to be together, and so we're thrilled to have the opportunity today to welcome some of our distinguished guests who are going to be giving plenary talks today. But before we get started, we always traditionally have the State of the Network address, and today I'm going to invite Mike Cohen to provide an update on the state of the network, and then I'll come back and introduce our two distinguished guest speakers. Thank you.
Good morning. I'm glad to see people here after the, what do we call the party? I don't know. There must be a better word. The gathering. I don't know. Networking. You know, Jeannie's got language, as you see already. Like a. Well, good morning. So this will be a little bit different talk this year because I'm going to talk more slowly so people will actually understand it, and there are some things to convey that I think are really important. So what I'll do is talk about our leadership, sites and research participants, and longitudinal achievements. The latter two things, it's time to brag, especially because Jeannie has just taken this job, and we intend to really show our best face to Jeannie and Carl. Carl knows us well, but now Jeannie's about to. So there'll be some bragging, and I apologize, but it'll be merciless bragging. And then I'll talk about our way forward including new biomedical tools and our strategies, and then transitions. This is your network, and I hope to convey to you that it is vibrant and strong and has every opportunity to make more contributions to the future that are as, and I'll use this word for Carl specifically, that are as transformative as in the past. You all know that Waf and I have had the opportunity to lead this network for more than a decade. You know our operations center with fearless leadership by Nero and Ayana. You know about our lab center, and you know about our statistical center. And we couldn't be prouder of the work that's been done. You know that we have an executive committee, most of whom are represented in this meeting. And you know that we are guided and really guided to a great extent by our committees, which span the important areas of HIV prevention, and by our working groups, which are cross-cutting. And so this has been a privilege and a pleasure to develop this group and to benefit from really kind of world-class expertise. Now, absolutely none of this happens without the community working group. And the FHI people have a very strong support system for our community working group, and we try and we do involve the CWG from the initial concept proposal all the way through dissemination of results and communicating with the community. This is built on respect, inclusion, and collaboration. Now, I think one has to own up to opportunities to do better. I don't think we've done a great job, even if we have a summary slide for the community, which we had in some of our talks, we don't do a great job of making all the information accessible. And at the networking event last night, I was talking to some of the CWG members who, you know, with the opportunity to hear that we just hadn't done as strong a job as we'd like. And I think from this meeting, and I hope forward, we'll put together a summary of our plenary talks, what they mean, what the intent is, why we think they're important for the community working group, so it's accessible. There'll be slides, of course, there are always slides, but the slides are difficult for even us to interpret, let alone, you know, some members of our community working group. So that's a new effort that I intend that we will do forthwith, if that's the right word. Now, bragging for a little while. This network has done a lot of stuff. We've completed, since the beginning, 78 studies that included 172,000 participants, 172,000, that's a lot of participants, with 800 publications at our 69 sites around the world in 13 countries. And I would just say that I think everyone recognizes that with these sites, this is not parachute research. These are really deep and meaningful relationships between all of our groups and these sites. And we've been blessed to have, you know, really wonderful sites over all these years. And that's been a real privilege to work in countries all over the world. Now, it's not enough to, the gross numbers don't matter. It's like we are focused on people at risk for HIV, and I won't read through the whole slide, but you can see we've had an opportunity to work with participants in all the risk groups, both in our international work and also, very importantly, in our domestic work. So that's been a really important aspect of the PTN. It doesn't work on one population, it tries to make a contribution in many populations. So we have had the opportunity to do 78 studies, but some of these, and all of them are important, but some have, we believe, are truly transformative and have had opportunity to shape HIV prevention in a global sense. Certainly, going way back, our nevirapine work with Brooks Jackson, who's back with us in some ways, Brooks Jackson, going all the way back to nevirapine, was a really important contribution. I think while it might be narcissistic, I think it's safe to say that we had a pretty big role in launching treatment as prevention with the 052 study that almost everybody in this room participated in. And that 052 study is held up to be a cornerstone of HIV prevention. The FIA studies that Wafas talked about so much demonstrate the power of effective treatment in a setting. We've done a whole series of studies related to TDF-FTC PrEP, and especially looking at some of the disadvantaged populations or populations that are harder to reach in the United States and abroad, and those have been important contributions. Then more recently, recognizing the importance of TDF-FTC, which is not going to go away, or TAF-FTC, which is not going to go away, we've also been concerned and been engaged in long-acting agents. And we had the privilege of working with ViiV over 13 years, really, to develop CAB-LA, which, as you know, is approved in many countries through the good offices of the NIH who held the IND. And so HPTN 083 and 084 are really major contributions, and I would call them transformative in terms of long-acting agents. We're proud of our collaboration with both the VRC and the HPTN and our work on broad neutralizing antibodies, which I'll say a little bit more about in a few minutes. And of course, I'll get to integrated strategies because all these tools are not going to work unless they're put together in some package that makes sense. Now, remember that when COVID came along, myself, Larry Corey, Kathy Newsel, and David Stevens had the opportunity to work with Carl in the COVID Prevention Network. And we tried to continue, and we did continue all of our HIV work in spite of all of our commitment of all the people in this room to COVID research. And we're proud of our work in Operation Warp Speed that led to 160,000 or more people enrolled in vaccine studies and tens of thousands of people enrolled in monoclonal antibody studies. We were able to make a contribution in the COVID vaccine development and in monoclonal antibody development. And I think that shows the pluripotential nature of the network, which is really, really important, as we talked about yesterday, because there are going to be other outbreaks of other things, and the infrastructure that the NIH has built is immutable in a sense. It is available, as Carl showed with COVID and the COVID Prevention Network. It was possible to become COVIDologists really in about a day. So there were no, it was funny because it's like there were no COVIDologists, to my knowledge. It's like Carl and Larry and I and others are talking on the phone and saying, oh, well, you're going to be COVIDologists, But it worked, so enough said. So we are proud of our contribution. So where are we going from here? What is our vision? We have to expand. We are obligated to expand the toolbox of tools that can prevent HIV, make them ever better, ever easier to use, ever better understood. That is our obligation. But those tools then must be integrated into a way, if you make the tool and no one uses it, it's really, really bad, especially if you spent $100 million to make the tool. If you make which is about the cost of making a new tool. If you make the tool and it's not integrated properly and used poorly, it's the same problem. So the vision has to incorporate this issue. So for the biomedical tools, we are committed to the existing oral agents as well as long-acting agents. We are committed to multi-purpose technologies that would allow us to treat STDs and HIV, to prevent STDs and HIV, or to prevent what's it called, pregnancy, to prevent pregnancy and HIV at the same time. And we're very interested, of course, in the biology of broad neutralizing antibodies. So I think it cannot be overstated how important it is the work that Sinead, who's with us today, is doing in understanding CAB-LA in pregnancy. We have this unbelievable, unique opportunity with this long-acting agent that's given to many young women before they become pregnant. And because the drug has such a long half-life and because of its strength in preventing HIV, women are then exposed to this drug during pregnancy. And so we are going to see whether this is a class 1 drug. There are very few entirely safe in pregnancy drugs. We are going to be able to say this drug is probably entirely safe in pregnancy. And so I can't tell you how excited the network is about this observation. Now, it was no accident that Jeff Stringer came yesterday and talked about handheld ultrasounds and AI-driven, deep learning-driven handheld ultrasounds that are now available. It is our intention to make those, to educate the use of those ultrasounds for, at first, our 084 sites, and then make them broadly available for the network so that we can use handheld ultrasound in women of childbearing age who become pregnant, and really change the kind of dynamics of how we look at safety during pregnancy and help women during pregnancy. So we're very excited about those devices, and Sinead and Jeff Stringer already had a chance to talk about it, which is great. We are well aware that ViiV has got a new formulation of CAB-LA. It's a completely different formulation. It will last 4 months instead of 2 months. They are in early trials now. We hope to collaborate with them on that product as it comes along because of our strong relationship with ViiV. Lastly, I would note, before I leave this slide, that there will be a cabotegravir symposium at IAS. Many of you go to IAS, and there'll be a symposium about CAB-LA led by our own Sinead. So I would strongly encourage you to go to that symposium. Now, we are aware that there are going to be alternative agents. Inevitably, Charlie Flexner gave us a very nice talk yesterday about, hey, CAB-LA is not the end of the story, and of course there is ultra-long-acting PrEP, we'll call it, lenacapavir, that should last 6 months. We are partners with Gilead in these studies. They have Purpose 1, 2, 3, and 4. Purpose 1 and 2 are their licensure studies. Purpose 3 is a study of women in the United States, acceptability, and Purpose 4 is a study that Sunil, who's with us today, will look at people who inject drugs and the safety and acceptability of this long-acting agent that could be a powerful tool to deploy. I must slow down and just indicate that slowly that the 102 study was led by our friend Dr. Ada Adamora. Many of you knew her, a very powerful force in the field. After a very long illness, she died last year, early last year. But we will continue the study, and her leadership in this should always be remembered. Now, I've emphasized over and over, we cannot abandon Truvada, TDF-FTC. It's going to be generic, but it cannot. It is the mainstay of prevention, and it's a really important agent. And the 211 device, the 211, that's the device, the 211, Jeannie, what's the 211 regimen? Jeannie's got a whole new role as my wordsmith. The 211 regimen, the 211 regimen, is really important. It has demonstrated its benefits to men who have sex with men. And it's important that our network, Craig Hendricks and Mark Marzinki and others, have developed a behaviorally congruent douche product that might serve in a similar way as like kind of a easier to use product, like 211's easier. We think it's more acceptable. This rectal douche, we're very excited about its beginnings. And it really has left, this has been in a gate. It's like a horse race. I don't know how many years the horse has been at the starting gate. I'll ask Mark, how many years? So we had a race that started 10 years ago, and the gates finally opened, and this study is going to, 10 years is a long time at the gate. Most people wouldn't stay at a racetrack that long. But so this will leave the gate this year. Now, you heard yesterday, you know that NIH, I think rightly, there's been much concern about women not getting the same benefits as men, of a lot of discovery, and especially when it comes to the dosing of TDF-FTC or TAF-FTC, which we don't really think of as anything other than daily dose. It is possible they can be used less than daily. Jeannie's article I put on there, not to be too sycophantish, but Jeannie wrote an article about like less than daily dosing, realizing the importance of this. And there are other articles on less than daily dosing, and Mackenzie Mitrell yesterday was here, and she and Mark intend to collaborate on putting together opportunities to look at TAF-FTC and TDF-FTC and understand what is the best alternative dosing schedule. Is there a 2-1-1? And all of you heard, and many of you talked about that talk, is 2-1-1 a dosing schedule that's possible, or is it 2-2-2, or is it 2-1-2? Or, this can be explored and maybe lead to guideline changes, and so we're quite excited about pursuing this. Now, an alternative idea is that if you packaged TDF-FTC with something that must be taken, that young women or women felt they must take, maybe TDF-FTC adherence would be much greater. And so we are working on the co-formulation of TDF-FTC with birth control, or TAF-FTC and birth control, but our first study is TDF-FTC and contraceptive agent, and we hope that Viatris has been making this and going through all the licensure requirements to get this out of the gate, and we hope that Lisa Haddad, our lead of this study, will start this year with this MPT, our first MPT study, and it'll be very interesting to see if our hypothesis is correct. If you put this together with oral contraception, that is TDF-FTC with oral contraception, will we see a huge benefit? Now, you heard a lot from Dan Baruch. BNABs are sexy. And you heard a lot from Dan Baruch about the triple drug combinations. We are partners. We had the opportunity to partner very successfully with VTN to put together to do the antibody-mediated prevention trial with VRC01. We showed in a series of papers the benefits of that agent and its potential, but clearly a single antibody is not enough to act as an alternative to a small molecule. If we're going to make a BNAB combination, or BNABs that will prevent HIV acquisition, it will have to be a combination of drugs, either engineered by a company or using the proteins, the antibodies we have available. And we are committed, I believe, to an exploratory phase 2 study with VTN of a couple of hundred subjects to use the 3 drugs in combination and explore pharmacology and safety and acceptability questions that have not yet been answered. And then a decision will be made about can a BNAB product, a triple drug combination BNAB product, successfully compete with small molecules. The milestones for this have been set by NIH and this collaboration with VTN and VRC01, and we will try and meet those milestones if our ongoing research proves appropriate, proves that this is a agent that could be developed. There's a lot of advantages to this, very safe, long-acting, an alternative to small molecules, protects the integrity against resistance of small molecules, but we'll have to see how all the stars align over the next couple of years. So that's kind of not every tool, but that's a lot of the tools we're thinking about. Now we have to think about how those tools can be deployed. And I think the network, this is a slide from Waf and I in the very beginning of our leadership, where we said, well, this is the only way to do this, a status-neutral approach where anyone who gets a test, and what's been emphasized over and over in this meeting is the beginning of all this is testing, know your status, and that we would have a prevention opportunity for people who are positive and people who are negative, people who are HIV infected, I should rather say, and people who are HIV negative. We would have an opportunity for prevention activities, and that has been our goal, and we would recognize that some places have globalized epidemics and many places have infections acquired in smaller groups but that are at high risk. And so this has been the kind of mantra of the network. Now, so the integrated strategies, I can't talk about all the integrated strategies in this short talk this morning, but I can indicate that a very powerful and unique study has been done in transgender women in the US and Latin America. That study is completed, and Dr. El Sadr will have more to say about that study later this morning. We have completed a very difficult study. The network has completed a very difficult study looking at people who inject drugs using vans in several cities in the United States. These vans bring to the community the tools that have now been integrated. They're integrated into the van. And this study has been completed, and Dr. El-Sadr will have more to say about this study later this morning. So I won't kind of belabor the importance of these studies, but we're very proud. Let's stop and have a round of applause for. I do not believe, in all candor, I do not believe we believe that maybe these studies could really be completed, because these were really difficult studies. So I congratulate the investigators, and again, Wafa will have more to say about this. Now, probably the biggest network study that you've heard about, but it's unusual for us. It's a domestic study called HPTN 096. Dr. Byrer and LaRon Nelson and others, he's here with us today to bask in the glory of this slide. This is a study that's been many years in the making, trying to wind its way forward of trying to prevent HIV in communities at high risk in certain cities or certain places in the United States, in the South in particular, where most of our epidemic is. And we're trying to, Robin Fanfair was here showing you we have 31,000 cases a year. Can we drive that down with a set of tools put together in a package that would be acceptable to communities at the highest risk? And that's what 096 is doing. I won't go into the detail of all the integrated strategies that they're putting together to try and deliver this successfully. This study has kind of left its pilot phase and is in kind of leaving the gate with an opportunity to be a very large study for the network and to make a really big contribution. And so we're going to hear more about it. You will hear more about it in your network in the coming years. Dr. Bookbinder is with us, and she is leading a study called HPTN 113, which we're quite excited about it. And you'll see on the slide on the right that there are men, both heterosexual and heterosexual men, have considerable risk of acquiring HIV, and Dr. Bookbinder is putting together a study will lead a study that will deliver PrEP, we hope, effectively to men at the highest risk, and it will also include the now very popular DoxyPEP, which I'll have a bit more to say about in a second. And Dr. Bookbinder has done great work in San Francisco with DoxyPEP already, and so this kind of approach using more modern social media tools delivered or made available, and through those tools making available these agents, we're quite hopeful that this will make a contribution to people at risk for HIV who have really not had an opportunity to have prevention strategies before this moment in time. So we're quite excited about this study. And it's leaving the gate. In moving forward, we have vanguard smaller studies that sometimes have remarkable power and lead us to believe that they can go big places. So one of those studies we heard about yesterday, HPTN 111, the barbershop study. A simple but elegant idea that why not try and have men tested and benefit from opportunities for HIV prevention discussions in barbershops. And so our colleagues in Uganda have enrolled very rapidly and successfully into this study, and we'll look and see what the results are. But we're very optimistic that this is a really good idea that might be deployed more broadly and realize a really important potential in some of our countries. Another study led by Sarah Rutstein is one that is really transitional for us in the sense that STIs and HIV should not be separated. STI clinics are places where we find people with acute HIV and unrecognized HIV and unsuppressed HIV. And so STI clinics are really important to us. And we have a lot of STI clinics in our network. At least 22 dedicated STI clinics. So Dr. Rutstein's using the Malawi dedicated STI clinic to navigate PrEP in men, and these are our men studies, as you can see on the top, because we think men haven't received as many opportunities for prevention as women, and so these are as a men's study, and Dr. Rutstein's enrolling this very quickly and successfully in an STI clinic in Malawi, and we're optimistic that this could be important to us and also emphasizes the STI issue, which I'll say a bit more about in a second. I would also point out that Dr. Rutstein is partners with Dr. Marzinki and Dr. Eli Rosen on an alternative way of looking at adherence. Adherence you can look at in dried blood spots or blood plasma or clumps of hair, but you might also look at an individual strands of hair subjected to a laser that can see blood levels or what has been delivered day by day by day by day. So we are exploring this laser-directed adherence in this study, and that could be a really important new method tool for the network. So a couple of tools I want to slow down and emphasize. One is the handheld ultrasounds, which we think will kind of revolutionize management of women during pregnancy, and this hair idea, laser-driven hair exploration, could be really important to the network. It only takes, for a guy like me, you can see I would be challenged in this study because of limited hair, but it only takes a couple of strands of hair that you pull out with a tweezer. So STIs are really important. Well, we've talked about global HIV a lot at this meeting, and everyone here is pretty much an expert on this, about the kind of incidence in their country. STIs dwarf HIV. I think we are committed to having an opportunity to play a bigger role in STI prevention. And along those lines, we are concerned about diagnosis, prevention, and treatment, but we're a prevention network. And so Dr. Marazzo and her colleagues in the IDCRC started a study with the Men-B vaccine called Bexsero, and we've had the opportunity to have 6 sites enrolling subjects. We've enrolled several hundred subjects, and we're particularly excited about the fact that we're enrolling women. We have the permission to enroll 300 women, and we'll see how this goes. Soon we'll know the effects in men, or the benefits in men, and we're very optimistic that a gonorrhea vaccine is possible. But there are many questions in the STI field. Dr. Ken Mayer is collaborating with the IDCRC and DMID about the possibility of a neurosyphilis study using oral agents, alternative to benzathine penicillin. There's just a lot of opportunities in this. And this is a collaboration then with DMID and DAIDS. You saw Emily was here yesterday making brilliant comments. And then the ATN, we are pretty committed. We hope we're committed to a collaboration with them, which I'll mention in a second, and others. Now, recently, doxypep guidelines for men came out based on studies that were done, but women, again, were left behind. Our colleagues at the ATN are developing a study for doxypep for women in the United States, and we hope to collaborate with them on that study, and that would open the door for us to do a doxypep study globally if we're successful in collaboration with the ATN. So this is aspirational, but we hope we can do such a study, and again, bring women on board and make a contribution with the expertise of our network. So it's kind of time for me to talk about transitions. So the network, I think you can see, has made a lot of contributions, is very robust, and is doing really interesting, good things that can really contribute to health worldwide. But there have to be transitions. So we had regional meetings in Cape Town in September 27th through 29th of 2023, and that was very useful to meet with our colleagues and collaborators. We learned a lot from that meeting. We intend to have a meeting, a meeting is planned for October 4th and 5th, preceding HIV R4P in Peru. And again, we'll learn a lot from that meeting. Transition requires that ever younger people join the network and play a role. And so we started the Scholars Program many years ago with the help of our leaders. And the Scholars Program has had 48 US scholars and 15 international scholars. And these scholars have been, and you heard the scholars yesterday, and you saw how inspiring they can take old data and make it vibrant, which is hard for most of us. And so the scholars have been very successful with a remarkable number of RO1s and other awards, and playing leadership roles, importantly, leading protocols in the network, which is the whole point of the Scholars Program. It is to enrich the pool of investigators with people who we had an opportunity to work with and train. Now, the other point about transition has to do with leadership. I think it's no surprise that we, earlier this year, the network leadership, asked who would like to take over and lead the network. Wafa and I have had the opportunity, a privilege, to lead this network for more than a decade. We've done the best job we could do. I mean, we've heard a lot of, we'd like some compliments, but we've heard a lot of criticism. So I mean, I've got to say, we've heard a lot of the things we've done wrong, I'm quite comfortable with, I know all the mistakes I made. I'm not quite sure what went right. I've tried to emphasize that in this talk. But we had this privilege of leading this network for more than a decade. We had the privilege of working on COVID with you. It's your network, and this was an opportunity for us that I think we both enjoyed. But we earlier this year, indicated that it's time for change in leadership, and we had applicants, and among those applicants, the leadership committee identified the 2 new leaders, and the process will be as follows. New leaders will join WAF and I for a year, during which time WAF and I will remain as network PIs, but at the end of that year, at this next meeting, the new leaders will run this meeting. This is my graduation speech, okay? Okay, and her, this is a graduation speech, and I cannot say how pleased I am. The talent in our network allows us to have Dr. Landovitz and Delaney. So we are really lucky. Landovitz is somewhere off somewhere. Delaney is here. All of you, Delaney I've known her as Delaney. I never could. Her married name has never gone through my head. So only Rafi can pronounce it. But Moretway. I'm sorry for butchering that, Sinead. But we could make these 2 investigators are super talented. Remarkably talented, super creative, and I could not be more pleased, and I know WAFA feels the same way. We are thrilled that they are taking over. So let me then, in my graduation speech, point out that none of this would be possible without these very deep relationships with all our program officers are here, almost all, Lydia, Bobby, Judy, and Carl and I think it's safe to say, have had a really great relationship, I would think. I hope it's true. At my end, it's true. I don't know what Carl's end. And of course, last but not least is Cheryl Zworski, who has been with us the whole time and has been I think and Cheryl is rather unflappable. I mean, she's just unflappable because the things that have happened to us together with Dr. Fauci and in this journey we've taken together over many years have been remarkable. Let me indicate that, of course, this network is entirely. We collaborate with the Gates Foundation and pharmaceutical companies, USAID, but we're an NIH network, and we're unique because it's not just NIAID. We have NICHD, NIDA, and NIMH, and so we have a robust and really wonderful relationship with these leaders of these other networks, and that has been, again, a privilege with all the other networks to work together. I don't have time to say everybody's name, but you know who you are. So I think for Wafa and I, and Wafa, you may want to make your own comment. You can have your own comment. I'll give her the microphone. It's been a real privilege to work with all of you, and we'll try and make this transition as effective and seamless as possible. So I think, thank you.
Thank you very much, Mike. And of course, on my own behalf, I think this has been an amazing experience, getting to know some of you in this room, many of you in this room over the past decade. It's hard to imagine it's been a decade, I have to say. But I think when you're enjoying the work as much as we have enjoyed the work and I have enjoyed the work, it just seems like a blink of an eye. So thank you for your support. Thank you for your dedication. Thank you for persevering, sometimes through tough paths, but nonetheless, I think your dedication is very, very palpable. I think Mike didn't say it, but we are going to become the elders of this network transition. But that's the right way to go, and we are very excited about I am personally thrilled about our new leadership and what lies ahead. So thank you again. So I think we're going to have some time for thank yous for a variety of different people after we hear our two guest speakers today. So firstly, I'd like to introduce Dr. Jeannie Marazzo. And I'm just going to very briefly introduce her to you. Many of you, of course, know Jeannie for years and years and years because of her engagement with the HPTN. But she's currently the director of the National Institute of Allergy and Infectious Disease, NIAID, at NIH. And so she is responsible for a massive research agenda that includes digging into the pathogenesis, understanding as well as diagnosis, prevention, treatment of not only infectious disease, but also immunologic and allergic diseases. And so she oversees a big chunk of really the NIH's overarching research agenda, both domestically and globally. Previous to that, she was the chief and director of the Division of Infectious Disease at the University of Alabama, as you all know. And she's a distinguished researcher in her own right. She's made remarkable contributions in the fields of vaginal microbiome, sexually transmitted infections, HIV, prevention, research, and much, much more. So we're very thrilled to welcome you back here, Jeannie, and in your new role, and to listen to you tell us about the agenda for NIAID. Thank you.
Thanks so much, everybody. It always feels like coming home, and I'm not sure it's diplomatic to say, but you do feel like my people. So, so let's just go with that. So I could never give a talk, and nor should I, that would summarize the state of HIV prevention and your role in it, because number one, you've heard a beautiful summary from Mike. I'm sure WAFA's was just the same, and you've been sort of treated the last couple of days to some really in-depth discussions about some of the science. So this talk is really not about that. What I'd like to give for you is more of a sense of what the Institute is like right now, where we think it's going, some key activities that are going to probably demand more of our time, some of which we didn't anticipate, which is always the case. And then think a little bit about the context underlying many of the decisions that you're going to have to make in the next couple of years. So a little bit of a different talk, and we'll see how it goes. And as always, I'm very interested in feedback. Let me know if it was useful. So I'm going to start talking about money and get that out of the way really quickly. It was an interesting year in terms of money for us. Where did we end up? Luckily, we ended up with a flat budget. You all know if you handle budgets, there's really no such thing as a flat budget. Once you have inflation, once you have additional needs, you still are going to be behind the 8 ball going forward, and that's true. However, this could have been so much worse. So many of you may know that when there are proposals for the budget, we get a proposal from the budget, for the President, from the Senate, and from the House Appropriations Committee. And the House Appropriations Committee last year proposed a 23.9% cut in NIAID, if you didn't know that. And it was just specific for NIAID. So you can, I'll leave the rationale for that to your own machinations. But it was quite punitive, very targeted. The only other area that was proposed to be cut was the director's office. So we really did dodge a bullet, and I'm not sure that is going to go away in the coming years. So really grateful to all of you who advocated, who stood up, who do the work that makes us so proud and essential every single day, because we can never just assume that we're going to continue to have the resources that we have been fortunate enough to have for the last several years. And on that note, this is what our budget has looked like. So we had a gigantic increase after the 2001 events of 9/11, largely related to bioterrorism and biosecurity threats, and then a concomitant increase in the late teens, largely related to concerns about respiratory viruses and Ebola virus in particular. And you can see that that actually has gone up to $6.6 billion, and we were level, as I noticed last year. So very excellent advocacy that reflects the work that all of you have done that allow us to make the rationale for this large budget. The 2025 President's budget request is shown here. NIH essentially has a level budget. We have a small increase of $19 million over our current budget. We'll see what happens with this. If you look at this pushed forward, that's where it puts us. We're still at the #2 spot, just below the National Cancer Institute, which, by the way, has had considerable cuts in the last year. So they, too, are facing challenges, although hopefully they will see a change next year, too. So just be aware, this is not necessarily going to be continuing to go in an upward direction in the face of ongoing needs, not just our needs to handle what you are doing with the HIV epidemic, but other things as well, and I'll mention some of those. I do want to thank those of you who replied to our request for input to our evolving strategic plan. Many people replied. I don't have the summary slide here, but I will be reporting back this summer on what we heard. We have a leadership retreat in the next couple of weeks to talk about the input we got. We have to do a strategic plan in a very specific, pretty boring, frankly, format every 5 years, but we're going to make it more interesting this time by creating some sort of special objectives for specific areas, and we're going to report back on those objectives every year. Some of the themes are as listed here. None of those will surprise you, but I do want to be sure that people know that this is really transparent. We haven't done this since 2017. We got sidetracked, of course, during the pandemic, but it's an opportunity to really, I think, take a very fresh look at what we should be working on. We have some cross-cutting themes that sit squarely within the culture and agenda of the HPTN, and those include addressing health disparities, advancing women's health, expanding research inclusivity, and supporting global health. And I encourage you to take a look at our request for information. Technically, the deadline for providing input has passed, but as people know, I'm very eager to get your thoughts. Several of you have reached out to me already, and again, we have a formal process for that. I do want to take a little bit of a step back and say that all those goals are really laudable. Strategic plans are laudable. They're necessary, I think, in my experience. But you can't really execute unless you have the people. And I am very concerned about the pipeline for us to do the work. And it's not just the physician-scientist pipeline. It is the pipeline of everybody who does the work, from the nurses in the research clinics to the pharmacists to the community outreach workers. It's a really hard time for everybody to try to commit to an uncertain future, particularly economically, politically, and in many places from a standpoint of conflict. So if you can't get the people together, you're not really going to be able to tackle these areas which we are really focused on: pandemic preparedness, HIV-related research, allergy and immunology, DEI, and of course our research infrastructure. So a couple of slides about why I'm concerned and what we're trying to do about this. And the reason I think this is going to resonate with you is that beautiful summary of the HPTN Scholars Program, which for me has always been a real model of how our networks could grow our most precious resource, which are our young people and the people who are going to take over for us in successive generations. So we already know that if you look specifically at infectious disease fellows, that has been declining steadily, only 2/3 of positions filled last year. And these are excellent programs. These are programs that people generally have to compete to get into. The number of NIH-supported postdoc scholars is declining, and the number of U.S. citizens and permanent resident postdoc scholars in the biological and biomedical fields is declining, about a 10% drop. So it's a serious problem. How do we address them? I don't have time to go into the sort of all of the issues today, but this is a nice paper that was in JID from Bogoma Tatanji that talks about how we can strengthen the ID physician pipeline, again recognizing that that is only one small part of what we need to work on. This other chart, which is a little bit harder to read, I particularly like because it lays out some of the challenges, and I'll just mention some of those to you. One of them is debt, right? People come out of training programs, not just medical school, but all schools, graduate schools, nursing schools, with incredible debt. And they really have trouble getting positions that pay well as faculty, right? We know that hiring salaries for assistant professors or for postdocs, everything really, it's not going to make a living wage, particularly in cities like Seattle, Los Angeles, Washington, D.C., et cetera. Academic job offers are often contingent on grant funding, which is getting harder and harder to get, and I'm going to talk about the pipeline, which is one of my major issues for NIAID. And then I'm very concerned about the fact that we cannot use some of our best resources, including international medical graduates who are often excluded for federal training grants and other opportunities. And we're working on ways to explore ways around that because we are really, really losing an incredible talent pool. So I think it's fair to say that NIAID has taken its, and again, no blame, lots of things to do, many, many priorities, but I think we've taken our eye off the ball in terms of dedicating funding and having a real plan for ensuring a healthy pool of research trainees. This is what, over the past 4 years, our training budgets have looked like. And honestly, given our total overall budget, this is pretty modest. And it's much more modest if you look at it as a percentage of our total budgets compared to what, for example, NCI and NHLBI spend on training. So we have now assembled a workforce or a task force to look at this. They're going to be assessing this in detail. We've got a number of contingencies planned, and I'm going to show you some of those. But at least we were able this year to increase by about $9 million our net budget for training. The overall goal is to continue to do this by maintaining what we know is a good T32 program, although that's a training program for many physicians and PhD scientists that many of you know about and probably have come up through, at least in the United States, but also we have a number of folks who enter from abroad. So the idea is to keep that program going, but also try to increase our budgets and our pay lines for Fs and Ks, because those are the real pathways, particularly for scientists to get into it. So just a promise that that is definitely on the radar. We can't have a situation where the pay line for, K grants is, which it is now, is about 13%, 14% for new investigators. That's just not tenable. So let's go very quickly in my last 10 minutes just to some content that I want to point out. Mike, and I'm sure you heard from others this week, the last couple of days, that the situation for STIs and hepatitis as well really is not good globally. I'll say one quick slide on HIV, but if you haven't seen it, I think this WHO report that just came out does a very nice job of painting a global picture of how incredibly common these infections are. And particularly sobering is that there were in the last, this is for 2022, 220,000 syphilis-associated deaths, including deaths from congenital syphilis. That's a lot. I'm going to talk about congenital syphilis in a minute. The only thing I'm going to say about HIV incidence has to do with HIV in this country, even though, of course, you need to talk about it everywhere, and I know you've been hearing about that. But I just want to point out, having come recently from the Deep South, that we have not made a dent in the incidence there. I'm sorry to say, we still, as you heard, and I think you heard from Robin yesterday, 31,000 new infections in the U.S., many of them in the South. And even in 2022, 2/3 of all new infections among persons with HIV attributed to male sexual contact. Unfortunately, many of these diagnoses made very late, which, as I have said many times, we experienced quite tragically in Alabama, where I often felt like I was back in the 90s or the 80s. So still huge problems. So great to see this group taking this on and tackling it and really addressing what I think is the underlying pathology here, or one of the underlying pathologies, which is stigma, because that's what's preventing people from getting tested and getting access to care. A word about doxycycline, PEP. I'm excited about DoxyPEP, but I have very mixed feelings about DoxyPEP. I don't have enough time to talk to you about that today, but I encourage you to take a look at this editorial that I wrote, which really gets to Mike's point about how, once again, women are left behind. There's no evidence that really supports or can inform recommendations for DoxyPEP in women, and that, frankly, that pisses me off. In fact, actually, the title of my editorial was not accepted at first. They changed the title because the title was a little too spicy for them. But I think this summarizes it well. But it really is an opportunity for us to take a step back in how, biomedical intervention trials really have to take a lot of complicated things into account. Women are complicated, right? Their reproductive cycles are complicated. Their biobehavioral worlds are often complicated. Everybody's is complicated, but they have some specific issues. So exciting, but take a look. Just a couple of things on Neisseria gonorrhea and increasing threat of antimicrobial resistance, just to point this out, not so that you need to read all the bullets, but a very recent report from the European CDC that I think is a great summary of what's going on globally. We, so far in the US, have managed to dodge this bullet, right? We have had only one case of significant ceftriaxone resistance, which was that we know of, which was successfully treated, but we really don't know what's going to happen. And there are some places, particularly in Southeast Asia, where the resistance to third-generation cephalosporins is increasing and only getting worse. We have some bright spots here. Some of you were involved in this beautiful trial that involved many countries looking at this new class of drug for gonorrhea, zoliflodacin. Also a nice model for how federal funding, in this case through NIAID and DMID, got this drug off the ground with early phase clinical trials and then partnered with a global partnership that managed to raise the money and conduct the study internationally to complete the phase 3 trial, which showed excellently that it was safe and as effective as standard therapy. So it's a very nice model, and I think when you're trying to get products out there that are not blockbusters in terms of profit, it's probably the only way we're going to be able to do this. Very similar to the Medicines for Malaria venture that some of you may be familiar with. Mike and I wrote a recent editorial that I'm showing here, not to be sycophantic with you, Mike, but I'm referring to what he said before, in case you didn't get that. Talking about the fact that, you know, we're only going to be able to rely on, I think, new antibiotic development and testing for, I don't know how long, maybe 5 to 10 years. We'll see what happens with ceftriaxone. So I think a vaccine is possible. I don't know that the first vaccines, i.e. the MenB vaccines, are going to be a home run, but even if they are a double, speaking as a baseball fan, or maybe even a single 33% efficacy, we might be able to buy some time, especially in the populations that are most at risk, not just for getting infected, but also for generating resistance variants. And that's the real concern in men who have sex with men, given the high rate of pharyngeal and rectal infections. And that's exactly what Mike and I, the point that Mike and I made in the model. So I just want to point out very quickly, I've shown that slide or that picture on the left, just the similarities between N-meninge and Neisseria gonorrhea. But the update here is on the MAGI study, which so many of you have stepped in, thank you very much, and really pitched in to start enrolling, particularly in Malawi, but also in several sites in the United States. The enrollment now is over 2,200 participants, and you expect to complete enrollment in the summer of 2024, which is just a few short days away. It's been particularly exciting to see this evolve. As Mike mentioned, this was my original study in terms of leading this, and so I can't wait to see what the results are. I know it's in great hands, and I'm very excited that you all jumped into this with such vigor and your usual competence. A couple of words about syphilis. Can't really not mention the increase in congenital syphilis cases in the United States alone. There were over 3,700 cases in 2022 with over 260 infant deaths. That's probably an underestimate because many congenital syphilis cases, as you probably know, result in spontaneous abortion, stillbirth that may not have been actually diagnosed in the context of maternal syphilis. This is not just the U.S. either. If you were at CROI last year, Angelica Mirando in Brazil did a very detailed and nice overview of the global situation with congenital syphilis. So this is a global problem that really is a public health crisis and frankly should make us embarrassed that we're not in a better place with syphilis. And to this end, Mike mentioned that you all are working on or thinking of working on a diagnostics. We do have a new RFA out that we think will be awarding very soon. T. pallidum diagnostics have not changed since I was actually probably in utero, let alone a fellow. And that is really depressing, right? You're still, I mean, just think of if you were ever a clinician, all the calls. I got so many calls a week, literally trying to interpret syphilis serology, and those were always the most interesting cases that people would ask about at conferences. So the fact that we're still struggling with a quantitative non-treponemal test to figure out if somebody really has active syphilis is another problem and a challenge in the field. Better news on the TB vaccine side, and I just want to mention that I think in the next 10 years, probably there are two, besides HIV, which I think you're going to hopefully take to the next level for control. TB and malaria are the most exciting fields right now to think about large-scale impact. And part of the reason I feel that way about TB is not just long-acting medication options, which are being studied and looking good, but also these new vaccine candidates, some of which have been very much supported by NIAID. So I will not belabor this point, but it's, I think, a very exciting time. And many of these studies are being done in people living with HIV, which is critical because, of course, TB is still the biggest killer of people living with HIV globally, a very sobering track, and here, very sobering fact. And here are just a few of the vaccines that are in the pipeline that are available and or that are being studied and I think should have some promise. Now, I can't not mention the biggest player on the scene. I always remember the first meeting of the Infectious Disease Clinical Research Consortium, which Mike mentioned, which was in January of 2020 in Bethesda at Fisher's Lane. And Tony was there and gave the opening commentary, and he showed a slide about SARS-CoV-2, and he said, you know, yeah, this is a concern. These coronaviruses can be really tricky. I have to go to a call with the WHO right now. So it's burned in my memory as one of those things. So let's hope that that's not the way this goes, but I am very concerned about this, and this has been taking up a very big amount of my time and the team's time. I think if you haven't heard what's going on, there have only been quote-unquote 3 human cases in the United States, all of them largely with conjunctivitis, although one case was a more of a respiratory infection. We don't really have very much information, and in fact, that's been the theme of this whole outbreak. Very little information, and we can talk about why that is. I think the other big concern about this is that, you know, it's in getting into peri-domestic animals. So if you haven't seen the reports of cats being infected and largely dying, at least a very high mortality rate on farms. So that just emphasizes that there's more risk for interactions between people and animals and more opportunities for this virus to mutate. I won't go through these, but the next couple of slides, if you're interested, I'm very proud of the Centers of Excellence for Influenza Research and Response, which had data on this problem weeks before any of the other entities, which made us a bit of an envy spot for many people, largely because these groups, which are funded by DMED, have been working with a One Health approach, right, which is animals, veterinarians, human specialists, epidemiologists. It's a fantastic model. So they actually had access to the farms, and they had access to samples way before anybody did. And we've already seen several papers in the New England Journal of Medicine and other places from these groups. So lots going on here. If you think we're busy, it is true. And we hope to be sure, particularly to show soon, although we have some preliminary indications, how effective the stockpiled vaccines that we have are against this new threat. So I am out of time. I could go on and on and on, but mostly I want to then finish really quickly by just reiterating what I believe your mission to be and why it is so critical, and that's summarized at the top. You had some beautiful work that was presented at CROI that again builds on the areas that Mike emphasized. Cabotegravir being effective in the setting of bacterial STIs, important given the syndemic. The HIV testing assay in the setting of using cabotegravir, which having chaired the what do we call it? Where is Sue? There you are, in the committee for serologic diagnosis. Anyway, it's the adjudication committee, thank you. I know how complicated that is. And the attention to comorbidities too, as shown there. And Mike already mentioned these 2 trials, so I will not belabor them. But again, I think these trials, bridging discovery to implementation, are such a wonderful hallmark of the network. You've got Purpose 3 coming up. And so I just want to really emphasize that you are a crucial pillar, not just for looking at these strategies for novel treatments and a cure, but also, as Mike emphasized, a resource for responding to public health emergencies, given your really incredible infrastructure and the expertise of your teams. So I'll stop there. Thank you, and look forward to seeing your next generation.
Thank you very much, Jeannie, for wonderful talk. And we'll have some time at the end for some questions from the audience, so start thinking of the questions now. We're going to go now to our second distinguished speaker today, and that's Carl Diefenbach. And as many of you know, he's the director of the Division of AIDS at NIAID and has been a partner with us in the HPTN for many, many, many years. And for those of you who don't know, Dr. Diefenbach's portfolio of work, really, he oversees DAIDS and its broad global agenda and broad research portfolio that's aiming at advancing the knowledge on HIV and AIDS, as well as, of course, in identifying new prevention as well as new treatment tools, and also in identifying potential cure strategies. We are very happy to have you back here at the podium, Carl, to give us an update from the Division of AIDS. Thank you.
Thank you. It is always a pleasure to come and talk to all of you, but I'm going to go off script for just a moment. I want everybody in this room to clap and thank Mike and Wafa for the leadership of this network. The style and grace with which they have led this ragtag group of people is just phenomenal. Years ago, Mike, we used to refer to the bus, the HPTN, as the little school bus. But it has grown into a full-scale Maserati-driven airplane that can go underwater and do anything it seeks to do. So we have really gone through a transformation within the HPTN. Next slide, please. Oh, I guess I can do that. So I'd like to, for this cycle, I've been really making a point to talk about the NIAID HIV language guide. And we have made a commitment, starting in 2017, to really help end the use of stigmatizing language. We're all aware that certain language is insensitive to people and their basic human dignity, and we really need to use and focus on person-first, inclusive, and respectful language. This guide lists out the newest versions of word choice that I think are incredibly important. We strongly support and ask that each of you take a look at this, and when writing grants, when putting together documents for protocols, use non-stigmatizing language, not just in meetings, but in all NIAID-supported activities. The link to the language guide is there at the bottom. Now, if you go to the website, this is what you see. The big blue box there is where you download the language guide, but also we've included some supporting materials that allow you to have some forms, some generic letters, and slides that you can use in the situations. We've tried to make this one size, doesn't fit all, but we've thought about options available. And I'd really like to thank the team at NIAID, at Hank, and all of the CABs and groups within the networks that helped us put this together. So it's been an important thing to update this. Other institutes are working on their own language guides for their diseases. I think we're all going to be better for this as we go forward. There's a new director at the White House Office of National AIDS Policy. Francisco Ruiz has been installed. He is on the job, and it's going to be a real pleasure to work with him as long as he remains in that position. We're working hard to make sure he gets to IAS and to R4P, and so we can all have a chance to hear his point of view. And at some point, like he's coming to the OAR meeting this week to make a presentation. It's really important that we acknowledge his presence, and we'll be able to work with him directly on many of the critical issues that we are seeking to push forward. I'm going to spend most of the rest of my time talking about the elephant in the room, and that is that every 7 years we renew the clinical trials networks. Halfway through that cycle, we take a pause and look at where we are, what we have accomplished, what we can really seek to achieve in the remaining half of the cycle, and also think about where we want to be 10 years from today, so that we engineer the FOAs and think about the long-range goals or long strategic planning for what we're seeking to achieve. So here's the cycle we're on. This spring we launched the process, and all the networks presented to the NIAID Strategic Working Group. We have been holding meetings, webinars, thematic discussions, coming and talking at network meetings, seeking stakeholder input. Hank had a webinar with us. We had over 400 registrants and 250 people showed up. This will continue over the summer, and we will continue to take input and ideas with the goal toward having a rough draft for our advisory committee in the fall. We'll seek continued input. Once we have that rough draft and some input from the advisory committee, we will go back out to community, go back out to stakeholders over the fall with a goal toward finalizing our draft for a presentation to the advisory committee in January, at which point we'll shut the process down, move into writing, publishing, reviewing, with network awards and site awards in December of 2027. But we are now in a place where we can really think about where we are in the current cycle and how we move forward toward 2027 and beyond. And one of the things I truly believe is this is an opportunity for experimentation. What can we do as pilots and tests over the next couple of years that allow us to be in a better place when we get to the new awards in 2027? So what can we accomplish between now and the end of the current grant cycle? What adjustments in structure and scientific direction should we test to see if we can accelerate the pace of discovery? And I think it's important that we start now having the conversations and figure out how we can build implementation research and implementation strategies into our plans. So what does the future hold for the relationship between NIAID and the HPTN? Well, we have new leadership that we're going to get to know very well. Those two are definitely not strangers for us, and I imagine Mike and Wafa aren't going to wander too far off the reservation. But in the meantime, I want to assure you that NIAID and the Division of AIDS are committed to HIV prevention across the lifespan. We need to really focus over the next several weeks to months on getting the report back from the SWG, from the 096 team, so we can then talk about facilitating implementation and further evaluation of 096. This has got to be a priority for all of us. We want to continue to advance novel prevention strategies and think about the ways to plan and complete studies to demonstrate impact. It's not just enough to prove that this is scientifically valid, but really think about impact. We have done this incredibly well within this network with 052, for example. We changed the face of how we talk about treatment. We talk about test and treat. We talk about getting to U equals U. It has really been successful. We can do more of that kind of thing. We want to, as I said before, establish pathways for implementation science research. We want to work within NIAID and the NIH to build a coherent plan for evaluating treatment and prevention strategies for STIs. And we need to continue to collectively engage on the ending the HIV epidemic research agenda. So some of you may have PTSD from these slides. We refer to them as the BRIC slides that we used now 3.5 years ago or 4 years ago when we were engaging in the last competition. They have all evolved. And I want you to notice the box at the bottom. The pandemic preparedness and response is a key element that we are going to continue to build upon for all of the network activities. Every network had a role and a responsibility in our pandemic response against SARS-CoV-2, and we want to be able to be ready when the next pandemic should emerge. Just to go through these reasonably quickly, this is the vaccine slide. For HIV prevention, you'll see the importance of implementation, the importance of linkage to behavioral and social science partnerships, novel prevention strategies, and the importance of key populations. For maternal and child health, cure is going to be a major part of their research agenda. The progress that Deb Prasad and her team have made is nothing short of phenomenal. Continuing to work on therapies, getting the best therapies for the youngest is going to be a critical part of helping us end pediatric HIV. And then in therapy, there's so much important work that can be done here in terms of complications and co-infections, continuing to work on tuberculosis. Therapy needs to evolve. We go from one pill once a day to injectables to where we're linking cure and treatment in ways that we can only dream of today, because we need to make sure that the output of therapeutics research ultimately is a cure for HIV. I would be remiss if I didn't take two of Jeannie's slides and point out that we do have, and we acknowledge, a major challenge with sexually transmitted infections. This is the problem slide, obviously. There is so much disease and so much we can do. But I think for our networks, the idea of focusing on vaccines is going to be a strategic decision. And I think that's where we really can make a difference. Vaccines are hard. Just ask anybody who's working on an HIV vaccine. And STI vaccines may prove to be equally hard. But we have a good one in study now. Let's see if either the Bactero trial is successful, or instead of using the cousin, use actual elements from the actual gonorrhea bacteria that will give us some level of protection. So I love this slide. What if we had a vaccine that prevented gonorrhea? Inspiration, assumptions, and aspirations. This is really the kind of work that we need to be able to have within the Institute that cuts across the barriers or the perceived barriers between the divisions. As all of you know, Emily Erbelding was the Deputy Director of the Division of AIDS. We have an incredibly close working relationship with DMID, and we can build upon that as we move forward. So let's spend a moment talking about seeking input on implementation science. These are the 4 pillars of EHE. Robin talked about this yesterday. For those of you that didn't have a chance to see Robin's talk, it was phenomenal. She just did a really great job. We have these 4 pillars: diagnose, treat, prevent, and respond. As we think about moving forward, we need to think about how we as a group are going to build implementation planning into our research. And I think it starts at the very beginning. When you have a concept that you want to move forward into efficacy, we really need to start talking about with development plans that go well beyond the phase 3 clinical trial. How we can start talking to the drug manufacturer or the vaccine manufacturer about what we will do for post-trial access, what we will do for open label extension studies. But more than that, how we're going to talk to PEPFAR and CDC and HRSA to get them aware and tuned in that these items, these new agents that will revolutionize our science are going to come their way, and make sure that they are linked in and part of that process as we go along. This plan must include community, all relevant stakeholders with clear roles and responsibilities. This was going to add a little bit of burden, but also maintaining these relationships through the long, dark period where we're undergoing blinded studies where we have no idea if the trial's actually working will be important, so that we keep the flame alive, so that when we have a success like cabotegravir, we're ready to roll in ways that we should be. Cabotegravir gave us a real surprise. The studies ended a year early, and now we're making up for lost time. We should all enjoy having that kind of a problem. This is not to blame ViiV, but really the team did such a phenomenal job on those studies that we were able to get the results a year early. But I want to start, and I thank Cheryl for this slide. She has been thinking deeply about implementation science and implementation science principles. And so if we think about how we as a scientific research network will approach this, is when we go to do implementation science, what are we going to implement? And it has to start with the needs of the implementers. I think that's going to be a principle that has got to be first and foremost. We need to make sure the projects are jointly led by NIH investigator teams and the implementing agency and organization. Everybody's going to have skin in the game. And one of the areas that I think we're really going to need to focus on is making sure the projects start on time and complete within a timely manner so that these don't drag on. We really want to be able to get an answer and get an answer fast. Furthermore, these do not have to be set up as randomized controlled trials. They don't have to follow the rubric of randomization. We should be able to do this in an open label way so we can monitor the progress as time goes on so we have a sense of what's working, what needs to be evolved so that we can get to an implementable set of activities with a given intervention. So again, we're going to have a new way of thinking about this as we move forward. And we, as I said from the previous slide, implementation development plans are going to be required. So if we take this and apply what's going on in EHE, there's a lot of small implementation projects, medium implementation projects that we at the NIAID and the NIH have initiated with the CFARs and the NIMH-funded ARCs. So there's a lot that we can really work on here together. But I want to propose an additional idea here. And that is, this is a slide that I saw at the ACTG meeting, and I think it's really an important thing that we can all get behind. And that is, as we think about not just viral load suppression, but we think about the goal of therapy, the goal of research, is good health-related quality of life. We build toward this vision of health equity for this population, whether people are at risk or living with HIV, of having a high quality of life. And this applies, I mean, I think that personally, healthcare and healthcare access is a right. I know there's maybe people in Washington that don't agree with that. But if we build this in, what has to change within the NIH in order for us to get to this? We need to be able to, there'll be a new OAR director over the next couple months. We need to be able to build in to the research agendas this sense of integration that diseases are not the sole propriety of a given institute, but there needs to be able to be cooperation and collaboration so that, like what we've done with NHLBI, cardiovascular disease, or osteoporosis, becomes something that we can routinely get help studying so that we can achieve this goal of good health-related quality of life. And if we build toward impact and make this the goal that we want access, equity for everybody, we can then incorporate these concepts of access and equity toward better health to help us build toward this goal of good health-related quality of life for all. And I think that's our goal for the next 7 years, and it needs to start now. So thank you.
Can you turn the lights on, please, so we can see each other? And then please now make your way to the microphones. We'll take some questions. And thank you, Carl, for this call to action. Very much appreciated. I have a first question for you, Jeannie, and you have, throughout your career, you've had like one foot firmly in the HIV space and another foot firmly in other traditional sexually transmitted infections. And I'm just curious if, what are the lessons learned from what we've done in HIV that we should kind of think about as we try to pull together a robust agenda to address the STI danger that's looming?
Yeah, thanks, Wafa. That's an excellent question. Well, the lessons learned, I think the biggest lesson is if you invest in the field, you'll get results. Because the investment in HIV has dwarfed the investment in many other fields, particularly STIs. And of course, we've learned an incalculable amount that has positioned us to, conquer things like SARS-CoV-2. And frankly, other fields like malaria and TB have benefited from all the structural biology in particular that we funded with HIV, but even the understanding of the immune response. Mm-hmm. So I think it's a message that if you really invest and you really care and you're strategic about that investment, then you can make it happen. I think we just have we've not had a community of will. And a community of like-minded scientists who really comes back to Carl's last slide about the whole person. People are more than just the pathogens that happen to infect them, right? They happen to get other conditions, and STIs go along with HIV. So if we take that approach, I think those lessons are probably the most important.
Great, thank you. And certainly in this room, you have an army here who joins you in this commitment, so thank you. Let's start with Chris, yes.
Hi, everybody. Good morning. Carl, thank you so much for the last 95. I think that's really inspiring, and also
I want to give full credit to the people who are listed on the slide. I borrowed this from Judy. But again, great ideas have many parents.
And also for noting the importance of 096 and all your support over the years. Actually, Jeannie, I have a question for you, which is, I'm sure you're following and tracking this emerging and really troublesome Mpox ongoing outbreak in the DRC, and that has recently broken out in Kivu province, in a mining area with many, many women, sex workers in particular, and the idea that, and with genital lesions, it's clear that now we're seeing that clade 1 of Mpox really beginning to look like an STD. Which is really worrisome. And then, of course, there's been an outbreak in South Africa, 5 cases, all in men aged 30 to 39, and 1 death in somebody with low CD4s. So, you hear the drum beats of what we've seen before. So, Mpox. Eek.
Yeah, another thing I could have included a slide on, frankly, among many. I think it's incredibly concerning. The DRC situation is very worrisome, and you may remember, I think it was a year or so ago, when the concept of sexual transmission was brought up, and people were like, oh, no. There's no way that it's sexually transmitted. Now we have, of course, exactly what we knew all along, or surmised, I should say, a really concerning outbreak in that area. I think the statistics, I saw that something like 36% of the women involved were actually acknowledged to be engaging in transactional sex. So it's clearly, and it's a perfect environment for the spread of something that's much more pathogenic than what we were seeing with clade 2. So it is a very big item on our research agenda. We're exploring, we actually have a very good intramural program that has been very active, that Cliff Lane has led in the DRC. We've got some great sites there. We're considering sort of a large comparative vaccine trial. The results for a very large TPOXX therapeutic trial will probably be out soon. I'm not really sure how that's going to go because there is so much disease. I worry that, and even with using TPOXX, in the U.S. during the outbreak, I guess last year, it was never really clear to me how effective that really was, especially just anecdotally, especially for people with low CD4. So once again, a huge spectrum of opportunity for us to step up, and we are definitely interested. And the intersection with HIV could not be more clear.
Yeah, and the concern about people with HIV is certainly profound. Yeah.
Not just with HIV, but also, of course, it's another STD that goes along with getting HIV. So if you're trying very hard to get people, get PrEP, again, that's where you want to be.
Yeah, thank you. Yes, please.
Hi, Cornelius Baker, and thank you very much for your presentation today. Just one comment, and then I have a question for Carl and Jeannie. The comment is just making sure that we focus on that part of the HIV workforce is also advocates. And in a democratic society, people who vote and are voting informed about these types of issues and what they care about. And we have to strengthen that. We almost lost PEPFAR this year. And we almost had severe budget cuts. And anyone who goes to the Heritage Foundation page and reads Project 2025 knows what their agenda is. And they are working hard on the Hill. Every scientist needs to visit the Hill. So this is where it leads to my question. One, stigma is such a confusing and weak word, I think, for people. And I think when it goes to looking at the data from the South in particular, how do we get stronger science that particularly helps people to understand what that stigma is, and that also is much more bold in speaking about the consequences of racism, transphobia, and homophobia? Because stigma sounds like the person's problem. And then secondly, implementation science and the scientific agenda that's proposed for the next network it's okay, but again, it's not bold or aligned with, it seems to me, what we hear talked a lot about, which is syndemic. And we don't know how to take care of syndemic people. All of our systems are failing. People who use drugs, people with mental illness, and a lot of gay people who are unhoused. And the data keeps telling us that the unhoused in the United States are a major concern. And we do not have research that is focused, because implementation science is what we should be calling real life.
Thank you.
Real life. And how do we get science that helps in real life?
Great. Thank you very much, Cornelius. Give an
Cornelius,
opportunity for...
this is Carl. I think having somebody like Francisco in the position as ONAP director will allow us to go back to a level of Obama-era integration where labor and HUD were heavily involved and engaged in the National HIV/AIDS strategy. That has all sort of fallen apart because NIH needs the partnership with these organizations. We're not a housing authority, but we need to be able to have these partnerships. And that's where I think the best part of federal government can come together. In terms of the rest of the diseases associated with syndemics, I think we really need to build a new set of strategies across the NIH to make sure that we are dealing not just with infectious diseases, but also dealing with the structural barriers that come about that we need to tackle.
Thank you. I think we need to,
Carl, that's really important. And with Francisco there, and Jeff Crowley and I are coming out with a paper in a couple of weeks, because it's also important that people know how Harold Phillips was treated and pushed out of the White House. The office was moved. A lot of us have had to say to the Biden people, we will not vote for you if you don't remake HIV a priority. Everything is politics. And we have to pay attention. Francisco will only have the power we make happen for him.
Thank you very much, Cornelius. I'm going to move on to, we have several other questions.
Can I just
I'm
quickly,
sorry, Jeannie,
Cornelius, thanks for your comments. Two things. One, with regard to doing the research in the populations we need to do. I hate to say it, but the scientists who review grants and who often review papers also have an attitude problem, because they are skeptical about whether you can do the research or those projects in those communities, right? There were many people who said the Latitude study, which just showed that the use of long-acting antiretroviral treatment in very difficult people who could not get suppressed using standard regimens, were not able to get suppressed, would never work. How could you possibly design a study in that group? And it was a resounding success. So the attitudes that those people are too difficult, that's
That's a problem.
Not good. I was going to use another word, but that's really, I think, unacceptable. Second thing is, I think if you think that the research in the South is not innovative enough, you probably don't know enough about it. So I would encourage you to find out, and I'm happy to talk with you, but there are some people who are not necessarily in this room who are doing some very edgy, cool stuff in the Deep South, and they just don't often get, in the big page, they don't get the attention. So if you talk to some of the people in the community there, which I'm sure you have, you will be very impressed.
Great, thank you. We're going to take, please, brief questions so we can get the people standing by the microphones. Go ahead, quick.
Hi, my name is Caleb Brown. Speaking on stigma, I want to voice my appreciation for bringing up the updated guides to inclusive language and people first language, because this whole week I've been hearing a lot of stigmatized language being used by leaders of the studies. I know it's not necessarily malicious in any sort of way, it just comes from a place of not knowing, but there are people living with HIV who are working on these studies, who are participating in these studies, and we notice, and it does make a difference whenever the inclusive language is used. So I would like to encourage all of the leadership here to please review, and not just review, but implement that language into your grants, into your communications with the people who are working on your studies. And again, thank you for the work that you've done. I appreciate it.
Thank you very much. And I think I think it's helpful if any of us does use stigmatizing language. I think it's helpful somebody to raise their hand and, and say, I think that's how we'll learn, how we'll evolve all together. So thank you. Yes, please.
Daniel Driffin, HIV Vaccine Trials Network. Going back to Caleb, as a person living with HIV, I've sat in rooms like this more than 15 years now. Hearing the word infected is an issue. Mm-hmm. So again, just thank you, Dr. Diefenbach, for lifting up the importance of reducing stigmatizing language in all of our efforts. Number two, I would also say thank you for your continued approach of real-life conversations at the different conferences that you've been attending. So you've been recording videos with HIV.gov with Louis Shackelford, and people are watching those. I think we have to never forget to bring down the science into bite-sized pieces for everyone to benefit. So again, just thank you and continue using destigmatizing language.
Thank you very much. Appreciate it. Yes, please.
No, thank you very much, and thanks to this morning, panel. My name is Ndando Yola. I am the Community Working Group Chair. I think there's a lot of call to actions this morning, which we are really appreciated, I think in particular by the Community Working Group. I'm not going to overemphasize the appreciation on the language, that is really becoming intentional, and I think as we've heard from the two speakers, it really affirms the work of the Community Working Group. And I think, again, to also congratulate, I think as part of calls to action is to really congratulate the new leadership that we have had today as well of the network, which we really are. We will work behind that leadership as the Community Working Group. I think we also to really acknowledge as well the move on the presentation that we've had on the plans for efficacy trials that are really including, intentionality about access to products, and I think that's one of the things that's really great. And I think all of these are really important for the Community Working Group and communities at large, and really affirming the work that we do and the messaging that we give out to communities. So I really wanted to acknowledge and say thank you to you all.
Well, thank you. So thank you all, and I want to, of course, thank Jeannie. Oh, somebody else?
Yes.
Oh, I'm sorry. Please, one quick question. Quick question, please.
Quick question.
Last one.
Yes. Thank you very much. I'm Dr. Ade from Bela, Uganda. And my quick question goes to Jeannie on strengthening the investigator pipeline. So the challenges we face on your side here in the US are even worse for us in the low and middle income countries. And in particular, for the non-doctors, the social workers, the laboratory staff, and is there anything in particular that you are looking at for the low and middle income countries? Because currently, I can tell you from our own institution, our lab staff feel like they are sample collectors. Nothing is there particularly for them that could prepare them to grow vertically. Because in Africa, if you don't grow vertically, if you grow horizontally, you are not going to be promoted. Because at the end of the day, the promotion will come with a bigger salary.
Yeah, I can't thank you enough for that comment. Maybe two related things. Yes, I hear you, and I could not be more persuaded that supporting the professional development of multidisciplinary team members, HIV is the perfect example. We would never have the success that we have in HIV care settings, HIV prevention trials, if you didn't have that, really. I mean, you've got the pharmacists, you've got the nurses, you've got the lab people, you've got the phlebotomists, you've got everybody. So I think it's really critical. We have a new director at Fogarty, who you may know, Kathy Newsel, who's a really incredible global health leader, very strong in vaccinology, virology. And she totally gets this because she has worked with teams like this across the globe. And so we've been talking to her about how to strengthen these opportunities for developing multidisciplinary team members. So look forward to hearing a little bit more about that. We probably will try to bring that up in our strategic plan. I'm not sure how far we will get this year, but it's definitely on the horizon and a priority. So thank you.
Well, thank you very much, Jeannie and Carl and Mike and all of you here. I think we